All right, well, welcome everybody. So welcome to Insider Tips for Sub-I Success. This is one of our educational webinars that we're doing just to support medical students out there. The whole purpose of this is to be super, super casual. And we're gonna just kind of describe what a sub-I is and how to be successful. Tonight I'm joined by my colleague Taylor and our awesome resident ambassador Katina. And I'll let them introduce themselves in a second, but let me introduce myself first. I'm Dr. Manoj Dalia, but just call me Manoj. And I'm a pediatric anesthesiologist by training. Disclaimer, Katina is also an anesthesia resident, but this is not a talk about anesthesia. This is about sub-Is in general, how to be successful. But obviously, if you had some questions about anesthesia specific stuff, we can also help with that at the end of the Q&A. So I'm a pediatric anesthesiologist. I went to University of Michigan for medical school. I did my anesthesia residency at Beth Israel Deaconess in Boston. Then I did my pediatric anesthesia fellowship at Cincinnati Children's. I worked for a couple of years in Kaiser in Southern California, and then 6.5 years at NYU Langone prior to joining AMBOSS. So next, I will pass it on to Taylor to introduce herself, and then Katina.
Thank you so much, Manoj. My name is Taylor, and I'm here from the AMBOSS team. Really going to kind of be in the background today. I'm going to be moderating the chat. So if you guys have any comments, questions, thoughts at all, throw it in the chat. I'm happy to write back and forth with you. And I'll pass it over to Katina.
Hi guys, my name is Katina Kassicieh. I am a intern at the University of New Mexico. Like Manoj said, I'm doing anesthesia, but I did a medicine prelim year, and I'll start my anesthesia years in July. So if you guys have any questions about that transition, I'm happy to answer them. Otherwise, let's get you through your sub-Is.
Awesome. And like I said, guys, for those of everybody who joined a little bit after, what I said was the purpose of this seminar is to be very casual, educational. I'll be utilizing the AMBOSS platform periodically just to kind of demonstrate some of the things that I'm talking about, but there's tons of resources out there. We obviously think ours is the best, but whatever you choose to use that works best for you guys, that's perfect. So already went through that. So let's start with what exactly is a sub-I. So sub-I is short for sub-internship. I guess some programs actually call it an AI or an acting internship. But typically a sub-I is done at the start of it's done during your 4th year, and many times like during the end of your 3rd year is when you actually choose your sub-Is themselves. Sub-Is are meant to kind of be like a preparation, like almost like an apprenticeship prior to going into your intern year. So this is like where you really start making that transition from being a medical student to an actual acting physician. So that can be a little bit intimidating. But generally speaking, sub-Is are graduation requirements. A lot of times they're in main core primary care specialties, such as IM, EM, or family medicine, sometimes some surgical specialties. But there's a wide range of things that people can treat as sub-Is, even though they may not be categorized as a sub-I. Sub-Is can obviously be done at your home institution, but many people choose to do it at outside institutions because they want to kind of expand their experience beyond their home. They want to use it as an opportunity to see how, maybe medicine or a specific specialty is practiced somewhere else. And some people use it as an audition. That essentially, that if you go there and you do a great job and it's a program you're really, really interested in, and you can get a letter of recommendation from there or get the residents to know you or the medical students, that can benefit you. So there's pluses and minuses to that. And some people, the people who are doing it earlier in the year usually are the people that are really particularly interested in that specialty or it's relevant to what they're doing. So the residents and the attendings know that. So they're going to know that you're going to be excited about it. And that's why it's really important to put your best foot forward. And even if you do a specialty like radiology, you're still going to be a doctor and you still need to know, you need to still be able to practice medicine properly and know certain things. So, just make sure that you give it at all. So Katina, what kind of what was your experience with sub-Is? What did you think was most important when you were doing them?
So I did my official sub-I that was required by my school for graduation in medicine because my school did not offer an anesthesia sub-I, and at the time no away rotations were allowed because of COVID. So that was kind of challenging, and we had to do everything in our home institution. So yeah, I did my medicine sub-I. I think it was a really good learning experience, because like Manoj said, at the end of the day, we're still going to be doctors. You should be able to manage someone's like hypernatremia. Just because you're not an internal medicine specialist does not mean you just pass off everything to them. So I think it's a really good experience, and you kind of just take away from it as like, oh, I use this to learn, even if it's not what I want to do in my future.
Awesome. Yeah. And, so first of all, a couple of things, guys. One, would be great if you could, in the chat, for those of you who've already chosen your sub-I, if you could kind of list what you're going to be doing your sub-Is in, that would be great. Just for a little point of clarification, like, even though we say sub-Is are graduation requirements mainly, and there's certain categories that can fall within that, but irrespective of that, whatever specialty you're going to be going into, even if it's an elective, that's consider that your sub-I. Like, you're going to treat that like the same way you would treat a sub-I, because it's really, really important to make a great impression on those kinds of rotations. For me, I did a sub-I in cardiothoracic ICU, because at Michigan, it was an anesthesia run unit. So it counted as a sub-I, and also I got a lot of like anesthesia critical care exposure, but also worked with a lot of surgical critical care. So that was a pretty awesome, experience for me. And it looks like people are putting in stuff. Cool. Vascular surgery. I like it. Emergency surgery. An emergency surgery ICU. Derm, urology. Awesome. It looks like and I see an anesthesia. I love it. And go blue. Go blue. I love this. Very, very big fan of one of the individuals here. Fan of all of you guys, but anyway. So let's move on. All right. So there's three major components to a sub-I. Usually like new patient admissions. Again, we're talking about more of a traditional sub-I, not like if you're doing anesthesia or something like that. There's rounding, and there's presenting your patients. And one of the biggest things that I would say is seek advice. Seek advice. As attendings, as residents, we don't care about your competition. We don't care about like you wanting to get the best letter of recommendation. All we care about is, how do you work in a team, and are you taking care of your patients? Those are the most important thing. But you're also kind of in the sweet spot right now, because you're not quite fourth years, or maybe some of you may have started fourth year already. But the important thing is, ask current M4s if they're around. I mean, I know that after match, a lot of times people just disappear. But ask current M4s, about their experiences, tips that they can provide you to be successful. You've worked with residents on your third year rotations, and if there are residents that are in the specialty that you're doing your sub-I, ask them as well. They may even know that if you know which month you're going to be doing your sub-Is, what attending might be on there, like who the chief residents are, and they can kind of give you little pointers to make sure that you're successful. So asking people is so, so, so important. Do you have any examples, Katina, for yourself in terms of like advice that you saw beforehand, or did you wing it? Like, what was kind of your experience with that?
Yeah, I mean, I asked two of the anesthesia residents I knew really well at my home facility, but because we couldn't do aways and our anesthesia sub-I didn't count, they basically told me, do whatever you want. But I saw advice from an attending who said that, like, I mean, medicine is the foundation of all fields, right? So that's why I chose to do medicine sub-I. And I think it's really helpful, because a lot of stuff we manage in and out of the OR is medicine related. So if you're like me and you can't do a sub-I in what you want to apply to, although it looks like most of you guys have your sub-Is in your chosen fields, I think choose something that people are like, it would be a good idea, or a letter from this person would make a big difference, then I would lean towards that.
Yeah, if there's anything, a lot of times I think people get this idea that you should only do a sub-I only in like the specialty you do. But I think that there's a lot of times where there's opportunities where it's still relevant, even though it may not be your specific specialty, where it can kind of support you and make you a more well-rounded doctor. So those are all things to kind of consider. But ultimately, letters from specialties that you're planning on applying to are going to be great. So let's talk about new patient admissions. New patient admissions is probably like the most terrifying thing of all time for most medical students. It's not even great, even like when you're first like an intern as well. But it's because at this time, as an M3, when you're first on your rotations, you're learning, you're applying the medical knowledge that you learned from your first couple of years to taking care of patients, but usually you're working directly with residents. You don't tend to have you have your own patients, but ultimately you're kind of working as an assistant to a lot of the residents. But M4 year, your sub-I is like time to like actually take on like full responsibility. You're going to be handheld less. They're going to be expecting a lot more out of you. You may not have more patients than what you had as an M3, but you're going to have a lot more responsibility and the expectations are going to be much higher. So because of that, preparation is absolutely essential. Okay. So Katina, from your experience, when you were a sub-I and you had new patient admissions, kind of what did you do to make sure that you were prepared prior to seeing your patient?
So I think a good thing, so pretty much in any field you guys go into, when you get an admission, you'll get like a tiny blurb, whether it's from like the triage attending or your senior or whoever's like supervising you, and they'll kind of tell you like why you're admitting the patient, even if it's just like admitting for pre-op for tomorrow. Okay. So at least you have kind of an idea. From there, I would use some resource. A lot of times I would just use like AMBOSS or UpToDate and kind of just look at like, what is a typical treatment of what this person's being brought in for, just so I have kind of a running idea in their mind, or in my mind of kind of like what I want to do for this patient, things I want to ask them when I see them. I think chart searching them before you see them is also good. By chance, maybe they've been at your institution a bunch of times or at least one time and have some kind of medical history that's on record. Super helpful. So you can ask them kind of, are you still taking your medications? Have you been following up with anybody? And if not, then you have to get like a full H&P, and that's important too.
Yeah, definitely. Like, remember guys, like for the most part, when you're going to be getting patients, a lot of times it's going to be mostly bread and butter stuff that they want you to be able to, that are really, really important types of cases, like symptomatology, but not anything that's going to be overly whelming. Though I'll be totally honest with you, that wasn't necessarily true of all of my patients. I had some patients that I was like, this is absolutely ridiculous. Why are you giving me this patient? But it happens. But most part, it's bread and butter. So just like Katina was saying, in terms of chart review, a few things that are really important, look at their past medical history, look at like all the various like comorbidities. And if there are things that you don't remember, like disease processes, then look it up, because you may not realize that it does, like you may have forgotten that there is relevance to like they're presenting like their chief complaint or like their initial presentation. So you want to look at that. And just like Katina said, that a lot of times people can also come into the hospital, to the ER, or wherever they're coming with previous hospitalizations, and similar presentation. So if you have that, then a lot of times you have a pretty good idea of like a working diagnosis, even before seeing the patient. But a big pitfall to avoid, and it's not just students that do this, but residents and attendings do this, is that they see patients that have a similar presentation to past hospitalizations, and then they skip a lot of the workup because they make an assumption that the reason that the patient's in is for the exact same reason as last time. Don't do that, because that's how things get missed. It's really, really, really bad, because it could be something completely different. It could be the same thing, or it could be the same thing, and then there's additional things that are being added onto it. And if you catch something where like other people are just kind of writing it off, and then you say, well, wait a second, maybe we should do this, you don't realize like how good you're going to look. And I know Katina actually has a story about this that she had like when she was in the ER once.
I actually have a new story because I had a second one and it just happened this week. I have a sub-I with me, and luckily like I follow a patient with her, but she's like primary responsible. As a person with IBS who has like known UC and came in, everyone was like, oh, UC exacerbation, that's the sign out we got from the ED when we admitted her. But my sub-I spent so long reading on things that present like UC and like told our team, we're concerned for colitis on CT, like why don't we work up all these other differentials, including CMV, turns out she had CMV colitis, and it's treated way differently, right? Like instead of giving her
Wow.
I know, super cool. I was so proud. I was like, oh my God, that's amazing. And the ED was just like, yeah, IBD exacerbation or like flare. Let's treat her with typical stuff like 5-ASA or whatever. So instead, she gets ganciclovir and she's doing much better. So super cool. I was like, oh, this is gonna be a great story.
That's so awesome. Yeah, I mean, a big thing, everyone, is to like recognize, like when you're first admitting patients, the most important thing, it's not about necessarily doing all the nitty-gritty. I mean, that is a great thing that the sub-I was able to do. The biggest things are like making sure you don't miss the big things, right? And honestly, that's a big thing. Like the way that you're gonna like actually treat a disease process, like from the beginning. I mean, it essentially saved that patient probably days of people wondering, like, why is this patient not getting better, and maybe even potentially getting worse. So this kind of like being on top of things, like, and I'm sure that in the history, there was things that made the medical student think like, maybe it could be CMV, right? You don't want to get into a habit of just ordering everything. That's not being a physician, right? You're not actually being an investigator. You're not actually thinking through logically why it is. But if you can make a really good argument for why something should be potentially like looked up, you look it up and see, and then maybe a little bit that'll be important. So just don't miss the big things.
And it's cool to note, like, you guys are still medical students. Like, yes, you're expected to more function in the level of an intern, but even then, she like turned to me and was like, I've been doing reading. What do you think about these differentials? And so we talked through them before she asked the attending about them. So if it was something crazy out of left field, at least you only said it to the residents. And so they're like, this is why we don't think it's that. But when some of the differentials, I was like, yeah, it absolutely could be CMV. We should test her for that. And then it's very impressive, right? Like I'm going to write her an amazing review now because she came up with all these differentials and her differential ended up being right, even though it wasn't what everyone else thought it was. So it's cool.
Yeah, when you do something awesome like that, you're going to get an awesome letter. Like people are going to just automatically assume you're awesome. It's just true. It's true. It happens. It's great. I love it when I have residents and medical school students do awesome things. So do an awesome thing and you'll be great. So just kind of like review really quickly, guys, just how I was like talking about, if you don't know like a specific, like disease process, like say you don't really remember what, let's see here. No, you definitely remember that. Like you don't remember like all the like the things about like graft versus host, or let's just do like polycythemia vera, because like I feel like nobody remembers that. Just want to like look up a quick summary because it may be relevant to your like a patient's presentation. If somebody comes in with acute abdominal pain and you want to be like, I don't remember the whole differential. Well, then you can look up a differential. You may have your own list, your residents may, but I think it's important about just having some kind of process and somewhere that that you can go to be able to find those kinds of answers. All right. And then, say you have a patient who does come in with like an acute pancreatitis diagnosis. Like one thing that we have like in our clinical mode is we have these acute management checklists. And just like how I was talking about, don't miss the big things. These are like the big things, like start oxygen therapy if hypoxic, and then you can just kind of go down, click them off. And if you do this, then you at least know that on admission, you're not going to be missing the big things that could potentially hurt your patient, but always still keep that working diagnosis in the back of your mind. One other thing that I think is important is that we get a lot of questions about, well, what are important disease processes? Like, what are the things that we should think about? Well, one, that's another reason to seek advice. Like if your residents or medical students say, hey, you're going to be doing this sub-I, I saw a ton of this stuff, then review that even before your sub-I so you're not surprised. But if you don't have that, you can also look, like a lot of times there are very common diseases, common symptom presentations, and you kind of want to just look at well, what could I look at for that? In AMBOSS, we have this on-call survival guide. So if you have somebody who comes in with something just kind of like nondescript or non-specific, like a headache, or you have somebody that comes in and they're having a hyperglycemic crisis, then this is a great place to just go as a really quick reference. All right. So next, let's talk about rounding. So rounding, when I'm talking about rounding, rounding means not necessarily like you have an admission like early in the morning and then you do like a quick afternoon rounds. This means like, like maybe the patient came a little bit later in the day, you don't have a lot of your team around, you're doing that initial admission, you're handing it over to whoever's taking, who's like watching the patients overnight, the night float, and then you're coming back in the morning and you're actually going to be properly rounding and you're going to be presenting to your attending after this. So one thing that I think is super important is, again, being prepared, and rounding is where you start really focusing on more details and making sure that there aren't things that you miss. So I have this 30-minute rule that I think is really, really important. And what that is essentially, think about how long you think it'll take to round on your patients. Then think about the worst case scenario. Say like there's overnight events, a patient may want to talk to you longer, and then add 30 minutes to that. And I know that might sound awful, but this is for your sub-I. It's like kind of like the last hurrah, just do it. Because it always looks better for you to be sitting down and reading in the morning or being available to support your other, like the other medical students on your team or the residents on your team who may have more patients than you, than for you to be running around trying to do your last minute patients. So all those things are going to make you look really, really, really good. Katina, what do you think are some like best practices for rounding? And like, what are things that people should make sure they don't miss when they round on their patients?
Yeah, so I think the best strategy is just do the same thing on every patient. Of course, every person's different and they're all in the hospital for different reasons, but I think the way you go through overnight events and then go through their vitals, go through their labs from the morning, and then kind of just go through their problem list. And I think it's a really, really important thing to understand the why. I love that phrase actually, because as you go through someone's problem list, I think a lot of people think it's unfair when an attending's like, well, how much pain medicine did they get overnight? And it's like, oh, I didn't write that down. Why would they want to know that? It's important, right? Like if this person was asking for their pain medicine advance from like when we have it scheduled or when we have it PRN, you need to go up on the dose and they're expecting you to make a change to that plan. And they're not asking to be mean, they're asking because it matters to the patient, right? So I think that's a really good example I can give is just kind of look at those little things, like look at their ins and outs. If they're there for, I don't know, if they have kidney disease or if they're there for heart failure and you're actively diuresing them, because that's something important that you don't want to miss. It's like, if they're not getting enough diuretic, you need to up the dose. So things that'll change your plan and management, I think, are little things that some people forget to look at sometimes. Yeah, kind of just making sure you know the little details about your patients. I think spending extra time with them in the morning and asking them questions can help you kind of dig through some of their new symptoms and that you don't want to miss. So someone's saying like, I was not able to sleep last night, a small thing you can add to their plan, like, oh, we'll give them melatonin at night. And that makes a big difference. Your attendings will notice that you actually care for the patient and you're not just there trying to like grind through your rotation or whatever.
Yeah, I think the why is really important. Like you want to make sure, like, first of all, I mean, you want to do all your notes, you want to write things down. It's really important. If there was any kind of management decision, like where like you change the management, you need to always understand what the reasons why you changed the management. And say your attending asks you, well, why didn't you do this versus this? You also need to be able to defend why you didn't do something. Okay. And let me tell you this, medical students, residents, attendings, most of them suck at explaining why. Lots of people don't know why. They just do things because they get taught. And like when I was an attending, the way that you would drive me the most crazy is by when I ask you why you didn't do something and you said, well, I mean, that's just how all these patients are taken care of, or, well, somebody told me to do this and you weren't curious enough to actually like understand the reason why. I'm telling you that do not do that. If you do understand the why, you're going to be in the top quartile of students. Like honestly, probably the top quartile of just like medical professionals. Like people just don't ever try to understand that. Like if you choose a beta blocker over a calcium channel blocker, be able to defend why you did that. You've chose a certain fluid at a certain fluid rate. make sure that you understand the reasons behind that. Because just like Katina said, if people ask about it, it's not because they're trying to be mean, it's because it's important. It really, really, really is important. If you say we went up on the pain meds, and you just, if you don't wait for the why, you say, so we changed the patient from this calcium channel blocker to this beta blocker because yada, yada, yada. And you don't have, and the attending or resident doesn't need to ask you why, they're going to be so happy about that. Like it's just going to show that you're just very, very strong at what you're doing. So yeah,
Another thing I would add here is, so you guys will be like, depending on your specialty, most of you will be using consult services, right? The thing that I kind of did a lot as a fourth year was just ask them why. So like if you're consulting cardiology and they want to change a medication, just be like, yeah, for sure, I understand. Could you explain that to me? And honestly, like 99% of the time, they'll take the time to write you like 2 sentences, like, oh, well, in cardiology, we found this, there was a study that showed this. And then when you're attending during rounds is like, I wonder why they changed that. You know the answer. So it's kind of cool thing to do.
Yeah,
it's
absolutely.
Helpful.
Absolutely. So, so like we said, for the initial admission, you don't want to miss the big things, but you have to realize, like, as you're caring for these patients, you have to realize you're going to be getting different laboratory studies, and you want to make sure, like, okay, am I missing anything? Are there things that, based on the current lab results, the patient's presentation, are there other things that we should be considering? So always keep that in the back of your mind. You have to realize that there's like various, like for like the case of acute pancreatitis, there's different grades of severity, and so you're going to want to also think about that. And sometimes you can't make these decisions about where they fall until a certain amount of time has passed in the hospital. But you should know that, right? It's not just like, oh, the patient's admitted and that's that. The way that they progress through their hospital course can matter. For example, like the Ranson criteria for acute pancreatitis is like really important, so you can just go, like, whether it's an AMBOSS or MD Calc or whatever, and you can just pull up a calculator to actually get your severity score. Like, you can't even calculate a Ranson criteria until 48 hours has passed. So like, if you catch this, like if you say, hey, so I calculated a Ranson criteria because the patient's been admitted for 2 days and this, and you present that, people are going to just be like, wait, what? Like, that's so good. Like, good job that you did something that detailed and you caught that, and that you didn't treat all patients as, oh, okay, all it is about ordering labs, seeing them, rounding on them, regurgitating a plan, and that's it. When they see that you're actually taking the effort to treat each individual patient as an individual, and you're not just, putting them in one big category, these things are going to make you just look really awesome. Like, I mean, just immediately. And then finally, we'll talk about presenting, and the big thing about presenting is just being a really, really, really good storyteller. And that takes practice. Katina, what are your like tips in terms of like presentation, etc., when either you're doing it or things that you notice that your sub-I does well and things that you think your sub-I could improve on?
Okay, sounds good. I think calling it a storyteller is exactly what it is. So attendings, like most people and most of us, have like a very short attention span. So you want to make sure you're not giving like a full H&P every morning. After you've admitted the patient or you're just rounding on the patient, just give the one-liner of why they're in the hospital and relevant past medical history. I don't need to hear that this person has chronic hyperthyroidism or hypothyroidism if they're in the hospital for, like, I don't know. Thyroid is a bad example because it kind of affects everything, and I caught that. But either way, you guys get what I'm saying. Anyway, so you want to tell a story, kind of like tie in the vitals, why they're relevant. Like if the person was febrile overnight and they weren't admitted for an infection, and now you're concerned that they got an infection in the hospital, that's something you definitely want to tell your attending or tell your team. So kind of just telling a story, and then it kind of lets people understand where your thought process is going, and kind of lets people understand why you want to make certain changes to the plan or why you think the plan is working well. If the patient's getting better, then maybe you don't have a whole lot of changes. And then, yeah, so other things, I think as you get kind of through your medical career, your presentations get shorter and shorter and more concise. As a sub-I, I think you'll still be expected to have pretty long-ish presentations, but you should be more able to pick up on what things are important that an attending would want to hear about a patient in a certain situation, and what things you could probably not mention. Like if the patient is there because their heart failure exacerbation, you probably don't need to tell the attending like their neuro exam, for example. So the things like that you should probably be good at as a fourth year, of like leaving it out of the presentation. So I think that's kind of long-winded way to say, like, just become more concise, try to really understand what things are important for them to hear about your patient, what things are not important, and kind of leave out the rest. They'll assume that you looked at it. I think that's a big thing. It's hard to let go of as a medical student, is like, if I don't say that the heart was regular rate rhythm, how will they know I listened to it? It's like, they know, they trust you. And if they don't, they'll ask you. So.
Yeah, I'll agree. I agree with that. So, generally speaking, you want to try to aim for like 5 to 7 minutes at the most for like an initial, for like a new admission. Just like, as I said about seeking advice, ask your residents about like, how does an attending like to be presented to? Because sometimes they do change it up. Like they want to, like, a lot of times people say, oh, chief complaint, and they build this story, and then they say that based on this is what I think it is. And some attendings want to know what you think it is right from the beginning, and then listen to your story. So there's lots of little variations, and it's better to know this ahead of time, because the attending is going to not say, okay, well, let the medical students, let the sub-I present it the way they want to present it. They're going to be like, no, this is how you need to present it. So just better to be prepared ahead of time with that. Also, a big thing with a presentation, when you're going through talking about it, yes, you want to talk about pertinent positives, like the things that are really important. But remember, because you've said that, hey, this is what I believe the diagnosis is, part of being able to prove that diagnosis is also by disproving other diagnoses. So just as when you're presenting a case and you're saying, okay, I believe it's acute pancreatitis, you want to be able to say the patient was negative for X, Y, and Z, whatever it may be, because when the attending hears that, they know you're mentioning it because you're ruling out other things that it's not. Because what the attending may do at the end, if you don't do that, they're going to be like, well, did you consider this? Did you consider this? Did you consider this? And if you've already essentially shown them that you've considered all those things, it's going to make everything go so much smoother, and that's going to build trust. So pertinent positives, pertinent negatives, super, super, super important. All right. And honestly, it's going to sound dumb, guys, but like when you present, one of the ways you get better is by practicing. I mean, unfortunately, I know it sounds dumb, but sometimes just like with friends of yours, if you just take 10, 15 minutes to just kind of go through it and make sure that you have your thoughts organized, it's going to make a big difference. And these are skills that you're going to use even like later down the road, many, many times. Okay. So learning how to really organize your thoughts in a really, really effective manner will matter. Like, for example, like in anesthesia, we do oral boards. And the reason that a lot of residents, and anesthesia residents, many of them who fail oral boards are not because they don't know the anesthesia knowledge. It's because they don't know how to actually verbalize it and how to organize their thoughts. So these skills are going to be really important for you down the road, no matter what. And I want to talk a little bit about pimping, because I know everyone's so terrified about pimping. There are people who pimp. Personally, I think they're the ones who are extremely insecure as attendings and need to like find some way to kind of prove their superiority by just being mean. Just ignore those individuals. They are who they are. Sometimes residents do that, but I think most of the time, most attendings, when they're pimping, is they're asking you about things that honestly you should know. If you think you're being pimped, then chances are it's just maybe you need to like read a little bit more or know a little bit more about your patient. Like, these things are important. It's important that you don't necessarily just know about your patients. It's about that you have a general understanding of other people's patients, because you could get asked about other people's patients. This is not like when you were in M3, you just focus on, well, these are my patients, this is all I need to think about. Now they're going to say, like, we want you to make sure that you're going to be able to work in a team setting. And are you thinking about other people's patients? Are you thinking about, well, what could you do to support them? And they could have taught about somebody else's patients and then asked you a question about it to see, like, were you actually listening, or was your focus just on your patients and not on all the patients that the team is taking care of? These are like the subtle differences, but huge differences that make the difference between an M3 and an M4 sub-I. So you really, really want to think about that. And sometimes the things you get pimped on are the things that you're attending, like emphasize over and over and over again. But again, you weren't listening. So don't do that. I mean, like, these are like freebies. And the reason they do it is because so many people miss the freebies. You'd be surprised like how low the bar is actually set for you to look like a superstar. If you just do the things that you're supposed to do, it's pretty ridiculous. So just some quick key takeaways, guys. Seek advice, like we've already been saying. Preparation. Those things are going to just make you look great and not look frazzled. Make sure you have some type of game plan or system in place, whether that's utilizing AMBOSS as a platform, your own notes, resources that your medical school provides, your own like separate resources, whatever it may be. Just make sure you have a very clear system on where you can access all that knowledge very quickly. Make sure you're round with intention, so that you have purpose, like you want to really get to know your patients in details and be that great storyteller. Okay. And we don't want you to just act like you're an intern, actually believe you're an intern. Because if you get to a point of where by the end of your sub-I, you're getting more patients, you may feel like you're being punished. But if they're giving you, if you start with like 2 to 3 patients and by the end you're carrying, say, 5, or your residents are barely like interacting with, like helping you out because they know you've got it, then you've done your job. And that is like the key way to get an awesome letter of recommendation. So definitely keep that in mind. Additional great habits: be a great listener. And being a great listener means to your fellow medical students, residents, attendings, and especially your patients. Professionalism. People are always watching. I know that Katina's had some examples of where people don't focus on professionalism, and we'll get to that in a second, but also avoid the P equals MD mentality for one last bit of your medical school career. It's so hard because M4 year is so awesome. Like once you get your applications in, it's so great. But just for your sub-I, like make this the best you've ever been. Just push through it, look great, and like the rewards you'll reap just from being awesome for 2 to 3 rotations will be huge down the road. So definitely do that. But Katina, why don't you kind of describe like some examples of lack of professionalism that you've seen in your...
Yeah, I think being late is a big one. I think a lot of people don't think through that, but if you are always late to coming to like pre-round on your patients or showing up late for afternoon teaching, stuff like that, it's like, it just shows for me, and I think other residents, and if attendings notice, like it just seems like you don't care, which never looks good. And I think that kind of ties into people are watching. Program directors absolutely talk, and if you're very terrible or very good, they'll find out. If you're in the middle, maybe they won't say anything about you, but if you're amazing, they'll be like, hey, do you want me to reach out to the program director of whatever you're applying to for you? Or I'd be happy to write them an email about you. If you're bad, they won't ask and they'll just send it, and you won't get an interview, and then you'll wonder why. So I think that's one. And then another one that I saw someone get really caught up in, which is unfortunate, the drama. There's a lot of not professional attendings and residents as well, and they will inevitably like talk bad about each other in front of you, and they should not, but that's just workplace drama. Do not involve yourself in it. Just if people are venting to you, just nod and whatever, but do not like interact. Even if maybe the person they're talking about isn't your favorite, just don't say anything, because it always gets around in hospital settings, and you don't want to be especially not during interview season. You don't want to be the person perpetuating departmental drama when you're not even in the department yet. So that would be my little professionalism spiel.
Yeah, I mean, I agree with it. I mean, the fact of the matter is there's lots of like really poor role models. And don't think that if you mimic that's going to like be your in. Just always act professional because people notice, you know. And I think like the late thing, it's also goes back to what I was talking about with the rounding. You know, even if you think, if you're like, I got here like an hour ago or an hour and a half ago, and you don't finish, you know, that's not an excuse. The only time it's an excuse is if you have like a disaster of a patient and you know that like for patient care, you have to do that. That's the most important thing. But then a part of that professionalism is also like notifying your team, letting them know like, hey, I need support. I need help. Don't try to be like a superstar. Don't think that if you do that, because a big mistake that a lot of like physicians make is they try to do it on their own. Like they think they can handle it. And the scariest like clinician is the person who doesn't know what they don't know, or doesn't know what they can actually handle. If you can show that like, hey, this is like way over me, like I need somebody to help me out, people will be there. People will be there to support you. You don't want to get yourself in a position where you could be in a bad spot. So yeah. So thanks so much, guys. You know, these were like final words, but this is kind of like a Q&A. We didn't want to spend the entire time just talking about the Sub-Is, like just talking and not having participation. So Taylor, are there any questions? Are there any questions from the audience that you're curious about anything? I mean, focus on Sub-Is, but also beyond that.
Yeah, no questions yet, but definitely we have some time, everybody. Definitely feel free to throw anything in the chat. We're happy to talk about anything that you'd like.
So I'm going to say one thing. I saw somebody who said pass equals good enough to get your MD degree. That's true. But pass is not necessarily good enough for you to get the residency that you actually want.
They were just explaining because someone asked what P equals MD means.
Oh, good. Oh, got it. I didn't see that.
Yeah.
Sorry. Yes, the pass equals MD mentality. Thank you for explaining that, Lauren. But yeah, so it's just people just try to get by.
Yeah,
Awesome, Lauren. Totally my bad. Apologies. Didn't see the
context.
Do you guys see in the chat, there's a couple questions that just came in. First one being, how do you suggest asking for a letter of recommendations at your OAs?
Okay, I'll start, and then Manoj, if you want to add in. So I think a good thing, you're doing an away rotation, they know that's what you're applying to. I don't know why they wouldn't, but if for some reason attending seems extra like in space, you could always just be like, hey, just so you know, I am applying to this specialty, and at the end of my rotation, I'd love feedback from you, or I'm going to ask for a letter if you think I did a good job. So just prefacing the week with that, or the month with that, or whatever it is. And then I would say that towards the end, if there was anyone that you felt like gave you a lot of really positive feedback, or I know some ways have like their director kind of like gather all of your reviews and put them together in a letter. Or if there's someone you really clicked with and you feel like they'll write you a really strong letter, which you guys are all humans, you should understand when someone likes you and someone wasn't a big fan of you. If someone really likes you, just make sure you word it properly and say, you know, would you feel comfortable writing me a strong letter of recommendation? And if their answer is, oh my gosh, yes, I would love to, great. If their answer is like, yeah, sure, if I have some time, I would just be like, you know what, thank you so much for your time. I think I'll ask someone else, because you don't want a wavery letter. You don't get to see them, and it could really shoot your chances at a residency.
Yeah, I think like you want to, like, one thing is like when you're starting the rotation, again, ask the residents, like, listen, like this is something that I really want to do. I think your program is awesome. I'm really interested. Could you give me some tips? Like, how can, like, you know, you've worked with these attendings before, this attending or multiple attending. What can I do to make sure that I stand out? You know, like I'm a really hard worker, you know, even if you're not, just say you are. I'm just kidding, but be a hard worker. And, you know, and just seek that advice early on so that you can make sure that you can continue to build and improve kind of throughout. Okay. Sometimes people work with multiple, we've had questions before where it's like, well, what if I work with multiple attendings? Then sometimes, like getting a letter from an attending that you've only worked with like a couple of times, because that's just how the rotation is not necessarily ideal. But one thing you can do is like with the coordinator, whoever's actually organizing these away rotations, sometimes like there's like a director, like a clerkship director, that can actually collate and collect like thoughts from multiple attendings to help formulate one singular letter based on that. And honestly, sometimes that can even be better than a singular letter, just because if there's like 3 attendings and they're all saying the same things about you, like same awesome things, then if anything, it kind of like proves that this wasn't like a one-off, that this is who you consistently have been throughout. So just thinking about that. But most of us are happy to write letters of recommendation if you've done a good job. And if somebody is hesitant, then I think it's always just important to just kind of reflect that, could there have been something that you could have done better?
That's a good thought too.
I see there's a bunch more questions in, so just to hit the ground running, any advice for balancing sub-Is and applying for residency at the same time?
It sucks, but make a schedule. I actually was just looking because I still have mine up there from 4th year. Like I made a little whiteboard month. And so that I would know like what days do you need to, like I sent my personal statement to 3 different attendings that I really trusted to give me feedback on. So I was like, deadline to send, so that it would give them 2 weeks to review it. Because you want to give, whenever something's in someone else's hands, give them ample time to do it. So if you're going to ask for a letter from someone you've been working with for a while, give them like a good month and a half to write it for you. Same with someone who you want to review your personal statement. That way you're not bothering them like, hey, can you have it back to me in 2 days? Like that's just not reasonable with people's schedules. So I kind of made my calendar or use a notebook or whatever it is that you use to keep track of your stuff, and just know like this is the deadline for submitting personal statement, deadline for editing ERAS, deadline for submitting your, what else do you have to do? I don't know, submit your application, a deadline to submit your rank lists, big things that you do not want to miss.
I think that there's this tendency in general for people to procrastinate.
Do not
procrastinate. I mean, the thing is, ERAS opens like early, like it opens like months early. You can start working on it. If you do things like in pieces over like a couple of months, it's super easy to balance. But most people, they wait till the last second to do everything and don't do that, because especially when it comes to asking for letters of recommendation, because one of the biggest delays of like an application being able to be reviewed is because letters of recommendation aren't in.
Yeah.
So get these things in early. Just submit. Start just filling it in bits and pieces, so that really the last like couple of weeks, all you're doing is really optimizing, like making sure there's no mistakes. Not actually doing it for the very first time.
Agreed. Make sure you get everything in. And there's a way now that you can see how it will look when they print your application. I don't think enough people do this, but look at it. Click the like download, see how it's going to look when they download it. I had a friend of mine who printed hers and like one line cut off at the bottom, and it was just like an awkward little sentence hanging at the bottom of her first page, and it was so funny. And I was like, I'm so glad you looked. So you like change the spacing. So it's important to do that, because that's how your application will look when they print it out.
Thank
Pro
you.
tip.
Sorry. Shifting gears a little bit, with the goal of, I really like this question, with the goal of quality over quantity in mind, how does a sub-I become more efficient? How can you make it more efficient to allow for greater patient load? Again, with the goal of quality over quantity.
I don't think that your goal should be increasing your patient load. You're going to get the patients as an intern, I promise. I think your goal should be quality. I think that if you try to like say, oh, I'll take a new patient, and then your patient care starts to suffer or your plans start to suffer, people will notice that way more than you carrying a bunch of patients. So I'd say even if you only stick to 2 or 3 or 4 or whatever number, just make sure that you're doing really quality work. That matters way more than how many patients you have. Patients will come.
Yeah, and the efficiency thing, listen, everyone kind of like gets comfortable at different rates. Okay, like if, for example, right, like are you a high floor, are you a high floor person but a low ceiling person? Like if you're talking about like sports analogies, right? Like do you have a high ceiling? Like do you have like a high floor and a high ceiling? I mean, the fact of the matter is everyone kind of falls within that kind of range. And I think the worst thing people can do is start comparing themselves to everyone else. I know it's so hard. I know that's like almost impossible not to do. But the thing is, when you do that, you're not taking into account the fact that everybody realizes there's different levels of learners, right? And maybe in a year you're going to be a way more efficient than the person who's efficient for a medical student, but they could become really inefficient or they could never improve, right? Whereas you could like dramatically improve. So I wouldn't worry too much, because there's certain things you can control. So you should control those controllables, right? Which is like being on time, being professional. If that means, one of your co-medical students, co-sub-Is can show up an hour later than you and still get the same amount of work done, who cares? All people care about is, are you getting your work done? If you have to come in an hour earlier, so be it. No one's going to care about that. All they're going to see is that, like, okay, this person realizes that it takes them a little bit more time, but their work in the end is just as good, and they'll get better. Like, because the thing is, like, if you do the things that a lot of people just don't do, they're going to know that you have the work ethic to get better because you care. So I think you're going to be good. And I think that also goes along the lines of, there was another question asking, like, how do you navigate your sub-I when there's like another super interested sub-I on it? I think that's the same thing. Like, people notice when you're being a team player, and people notice people who are being gunners. Okay?
Yeah,
and I'm telling you, huh? What'd you say?
And yeah, not like a cool, you're being helpful and you're just extra efficient. Like, we had one try to start like drama because they were applying against each other, and one person started to try to like accuse the other one of, stealing their work or stealing their patients, or it was crazy. And it's just like, you know what? You're the one that's going to end up not matching. So just be professional, be above it, understand that there are plenty of residency spots. And if you both do great, you'll both match. If you're the one trying to like kick the other one's heels, you probably won't match and they will. So
yeah, just don't get dragged down by it. We notice. Like, residents, attendings notice. We know when a medical student is being particularly obnoxious. We do. So don't be that obnoxious person. All right.
Yeah. I think I had another one. I had something to say about someone else's question. Anecdotes about sub-Is. I think the only other one that really comes to mind is we have a current sub-I who is doing anesthesia with us, who just constantly talks about her home institution or experiences at other institutions, and how basically like putting my hospital down. And it's like, you just bought yourself a like do not rank situation. So even if the program's not your favorite, or there are things about the hospital that kind of rub you the wrong way, I just keep that to yourself, unless you really don't want to go there. And then in that case, don't do a sub-I there. But yeah, it's interesting. Like Manoj said, it is really not hard to stand out, because for some reason people do really strange things that just make them like likable.
Yeah. So I'm looking at a couple of other things that I think it can be just very quick stuff, and then we can do a couple of the other ones. If residents invite you out, and it's totally fine, you can definitely go, but just don't overly party, don't get ridiculous, don't not show up and like be ready to like take care of patients the next day. Like, just be smart about it. Don't put yourself in a position where you're gonna screw yourself up.
Agreed. Don't go get blackout drunk. Like, if you're going out for beers, which our department did all the time, and I went as a med student, be like, I'm having one and I'm done. Like, do not overindulge. Don't overindulge information either. They're trying to get to know you as a person, but as a coworker. So you don't want to be telling stories about how you were like blackout on the floor last weekend at a rave and like, just just remember it's a professional setting still. Yeah.
Just match first, and then once you match, then you can be like, hey, remember when you asked that question? This is actually the truth. These are the things. Just know when to do it, people. Just know when to say these things. Advice for students on sub-Is late in the season. I mean, P equals MD. At that point, I mean, if you're not actually good at, listen, you want to still learn, you still want to work really hard, but there's less pressure, right? Like as you start doing sub-Is later in the year, your residents and your attendings know that this is probably not the specialty that you're applying into, because the vast majority of people will do their sub-Is earlier on, if it's something that you're really interested in and you want to get a letter from. So still work really, really hard. But it's very common for residents and attendings to know that the work ethic may start sliding, but don't make it so bad. Like you still want to work hard because people still talk. And if they see that you're getting really, really lazy, like until like match happens, you're still being compared, right?
Yeah.
So you want to make sure that
February. So remember that even if it's January, their rank list isn't completed yet. So
exactly. Katina, there was a question about and this is great. So like about like AMBOSS online resources and talking about pocket reference guides. One little thing that I'm going to make as a disclaimer, there's lots of great ones, but I think one of the most difficult thing with pocket guides is ensuring that they stay current. And I think that can be a little bit of a challenge, but in terms of general stuff, I know that Katina has some that were some of her favorites that she used.
I had 2 books, Pocket Medicine and Step Up to Medicine. I think they're really helpful and they help you get through your differentials. But, and I know this is like AMBOSS, but honestly, AMBOSS is the one I recommend to like everyone that asks me, because there's a search bar, so it saves you a ton of time, and it's always up to date, and the references are at the bottom, which can honestly, like if you find something in AMBOSS you're curious about, you can go to the bottom, find the reference, click on the paper, and get to the like original source of that literature, which is something that is probably important to some attendings.
I think like, when I had residents that asked me like, Dr. Dalmia, what should I read? And I said, the thing that doesn't make you fall asleep. because to me, it's about gaining medical knowledge. And the thing is, if I give you a suggestion and you can't use it, like, or you're not going to use it, then it's a worthless resource. I don't care how good of a resource it is, it's a worthless resource. I think like, yes, like with here, we try to make it so that it's very streamlined. That's why we love AMBOSS, and I think that's why a lot of people love AMBOSS. And it started off for medical students, and now we're like it's kind of taking off with residents. But we want you to like be comfortable with things, and if there are things that like for example, like we have or we don't have that you love in something else, then that's something we love to hear about, right? Because what we're all trying to work to educate the students, educate residents, make better doctors. So in any way that we can do that, that'd be great, and in terms of, I think we can take a couple more questions. Question about sub-I at your school's flagship location versus more suburban rural. I think it really depends on what your goals are. Like if you're set on like, say you want to work in a rural practice and you're only applying to rural kinds of residencies, I think they'll love that. I think that if you have like a big flagship institution and there's like a big name, like you can get a really strong letter from somebody that's like, say, like pretty well known, then I think a lot of times that can be beneficial. I mean, I think it's not a black or white, like is one better or the other. It really just depends on like what your purpose is, like what are you trying to get at?
And to be honest, I don't think it matters. If you get a good letter from a complete random person, also a good letter is a good letter. So I think just try really hard and you'll do great, and your letter will be great and everything's good.
And Lucy, if you haven't used AMBOSS before, then
You're
use it.
missing out.
You can definitely you can download a trial. When people ask, when people ask me what's the difference between AMBOSS and UpToDate, just explore the platform. Explore UpToDate, explore AMBOSS, and you'll exactly see the difference. It's just UpToDate, I think, is a great clinical reference. It's a great reference source. But when you're talking about how are you actually caring for patients, you have to realize UpToDate is giving you a lot of the information about specific these processes and getting very granular, whereas all of the AMBOSS content is actually written in-house by physicians that are US trained and are actually writing the content from the eyes of a clinician. So when they're taking care of patients, they're thinking about, if I'm caring for a patient, what would I want to know? That's actually in the editorial description. When they onboard new editors, it's a part of the mantra. You need to write this from the perspective of what would a doctor want to know? What would a clinical year medical student want to know to take care of this patient to look great? And then you build in the layers to get those deeper dives. So check it out. I think it'd be awesome.
Do it. It's super helpful. I think more so than UpToDate, because there's more sections, just like Manoj was saying. You can look through differential diagnosis by symptom, which is something you cannot do on UpToDate. So it's really cool.
Yeah, I also, if any of you haven't tried it out, oh, sorry, Katina.
Oh, no, go ahead, Taylor.
Just wanted to say, you can always check out our website. Just go to amboss.com and you can always get a free 5-day trial when you are a new user. So I definitely recommend checking it out. And I'm also just going to throw in one last time our apps link. If any of you do want to try that out, it does run offline, just so you're aware. I know we're probably going to wrap up in the next few minutes. I did also want to say, I saw someone wrote a question about studying abroad and being in a, not in the US for their sub-I. While I know Manoj and Katina obviously studied in the US, we have a ton of IMGs at AMBOSS. So if you ever want to write into hello@amboss.com, our customer support email, they can connect you with an IMG who has gone through that and can give you a lot more specific advice.
I can also tell you, actually, one of the things that I do on the side is I actually help IMGs match in the US residency programs too. So I think that you can't think about things being traditional sub-Is when you're coming in as an IMG. I mean, a rotation is a rotation. Any rotation you do, you should be treating like a sub-I. That's really what it comes down to. They're not, again, sub-Is, when you're thinking about it, sub-Is are graduation requirements, but you can always act as an intern irrespective of which elective you're doing, right? So don't necessarily think about a sub-I is different than if I just did an internal medicine rotation. Just treat that internal medicine rotation as your sub-I. There's not a thing on top of it that says, oh, sub-I or whatever. They just want to see that, that you're really, that you work hard and, you'd be a good member of the team. So.
Totally.
Cool.
I can answer this last question because I think it was aimed at me. For anesthesia, did I do any aways at other institutions that I wanted to go to for my prelim year? So I'm in the unfortunate class that got COVID bound home. So no, I didn't get to do any aways. We didn't need them for graduation either, because it was at the time, I don't know, whoever the governing body is of residency told us we couldn't do away rotations, so we all did them at our home institutions. So no, I didn't, but it did affect my rank list for sure, and I'm glad. You guys should absolutely do away rotations if you can, because I ended up ranking my home institution higher than other institutions because I had never been to the city, and I was like, what if I hate it there? So it's terrible, but it's true. You're there for 4 years.
I didn't do any away rotations. To be honest with you, I was just kind of well, one, I picked anesthesia really late, and it was my a last minute choice because I was deciding between, I didn't really know what I wanted to do. So that's really scary going into 4th year. So for those of you guys, those of you who know what you want to do starting already, you are already ahead of me. But the other thing for me, it was that I wasn't certain that there was a particular place I really wanted to go. And so I was comfortable with my institution. I did a really great job there, and I got great letters from there. I don't think people necessarily expect you to do aways. Doing an away is really a personal choice. If you know there's somewhere you want to go, then totally, like it makes sense that you want to do it. For me, I didn't know. I just didn't know. And I think that's okay also. Like, you don't need to feel pressured to do an away, but a lot of people do aways because their home institution may not offer like the degree of depth in a particular specialty that they would want, versus another place. You know, I was just lucky at Michigan. They had that depth, like no matter what specialty I was doing. So
That's a good way to put it. Don't feel pressured. But yeah, if you don't want to stay at your home institution, do it away.
yeah. All right. Good night, everybody. Thank you so much for your time. Please send emails where we'd love to hear from you if you have any other questions.
And after today, you will all be getting a survey from us. So if you want to let us know anything about the way that we did this presentation, or just about AMBOSS in general, how it could further help you out even more, definitely let us know. We're definitely going to read all of that feedback.
All right. Bye, everybody.
Thank you so much, everybody.